It's been said that in life we are the sum of our choices, some big, like whom should you marry, others small, like which ice cream flavour to choose. On today's menu choice, it's skin deep, 5-fluorouracil or Imiquimod on that suspicious skin lesion. Is it as trivial as picking vanilla, or is there a bigger scoop to be had? Let's dig in with the 5 questions you need to answer. First up, let's compare the 2 creams and what they're licensed to treat within your skin. My first question is really quite straightforward. Do you have any of these skin conditions? Genital warts? Ah! Hold on a minute. Do you have Bowen's disease? 5-fluorouracil should be your preferred flavour because it works that bit better. And if you have actinic keratosis, I would guide you that way as well in your choice. As for superficial BCC, the Imiquimod flavoured cream, all things being equal, is that little bit more successful as well. Do you get sphenopalatine ganglioneuralgia? 40% of people report having experienced it at one time or another. You may know its other name as brain freeze. It's a headache caused by the rapid cooling of the blood vessels in the roof of the mouth. This sudden change in temperature sends a shockwave through the sensory nerve that your brain misinterprets as pain. And because the same nerve that provides sensation to the palate provides sensation to the forehead, voila, an ice cream headache. My wife always gets a headache at bedtime. Perhaps she's been eating too much ice cream. Both creams work in a similar way, killing abnormal skin cells, but in different ways. Your patients will literally see these abnormal skin cells die. 5-fluorouracil directly attacks cells with abnormal DNA, like a laser-guided missile. Boom! The effects come on quickly, but the effects fade faster and heal quicker. Compare this to Imiquimod, which is more like a guerrilla army, mobilised from within the skin itself to attack the abnormal cells. However, longer to start working and for the effects to fade after stopping treatment. Question 2. Prepare for side effects. I show patients pictures online of what to expect while being treated. This doesn't always work. This gentleman had a large superficial BCC growing on his chest wall. I explained to him that they expected side effects, but his daughter was horrified and dragged him back to me. Oops, include relatives in the discussion. My lesson learned. So how do you eat ice cream? Well, you put it in your mouth, don't you? Are you a nibbler or a muncher? Are you a licker or a dribbler? Know how to put these creams on your skin is important, or you won't enjoy their full benefits. Here's my recommendations for the beginner. For 5-fluorouracil for actinic keratosis or Bowen's, apply morning and night, thinly to the affected area and 1 centimetre beyond, to a maximum area of 23 by 23 centimetres. Imiquimod for superficial BCCs is 5 times a week at night for 6 weeks to the lesion and 1 centimetre beyond. For both, make sure you wash hands before and after applying. Side effects are to be expected: redness, crusting and an erosion of the skin. Use Vaseline to protect the area. Wash the area gently before reapplying treatment. Consider a mild to moderate strength steroid cream once a day to help if there's any significant itch or irritation. If the skin reaction is very severe, reassure your patient that's good, it's working, yay! But consider maybe reducing the frequency of application or stop the course if nearing completion. I follow up patients as follows. At 7 days, I ask, have you got the cream and started using it yet? After 3 weeks of use, I ask, how's it going? Have you noticed any skin response yet? Because there should be. Tweaking sometimes the length of treatment. I review 12 weeks after ending the course to check healing is complete and if there's any residual skin lesion remaining and whether another approach might now be appropriate. Question 3. Know how to use these creams. Do you know how to manage brain freeze if you get it? You press your tongue or thumb against the roof of the mouth to warm it up. This helps the blood vessels return to normal more quickly. With Imiquimod, you must tell your patients it stimulates the immune system and it can cause flu-like symptoms in 5 to 50% of patients, depending on the dosage and frequency being used. It's not dangerous, and if mild, this flu-like symptom can be treated with paracetamol, rest and fluids, like any cold. But if severe, may warrant reducing or pausing treatment. Question 5. Know how to deal with significant side effects. Can you use these treatments again on the same patient? Well, yes, you can, but perhaps only after full healing of the skin has occurred, i.e. 3 months. But sometimes a different treatment option is better. These conditions are caused by a lifetime accumulated excessive ultraviolet light exposure, so emphasise good ongoing daily sun protection with creams and sun hats after treatment. But the great thing about these treatments is they are home-based and ready available for use in primary care, as long as you know what you're doing. For extensive scalp actinic field changes with 5-fluorouracil, I try treating in winter time when there's less exposure to sunlight, which can exaggerate the skin response and any sunburn. So question 5. After treatment, know what you should be doing next. You now know the answers to these questions and can make a good diagnosis, hopefully with dermoscopy. You and your patients need to be willing to give it a go, and you're willing to follow them up, because your best patients are your teachers, but only if you choose to listen to them. As for you, doctor, your next scoop is to keep learning how to use that dermoscope and confidently make a diagnosis of actinic keratosis, Bowen's and superficial BCCs in your patients. So watch one of these 2 videos next. Now, all I need to do is decide which of these 2 bad boys I get to eat first. Why not both? Brain freeze! Apply morning and night, thinly to the affected area and 1 centimetre beyond, to a maximum area of 23 by 23. Oh, blooming it.